Welcome everybody. It's my great pleasure to be participating in the first live transmission from Alexandria University Cath Lab for a case of CRT implantation. I am Aly Abo El Hoda. It's my great pleasure to be in this session with my great professor, Professor Peter Brady, Professor of Cardiology and Electrophysiology in Mayo Clinic, Minnesota. With me is Dr. Ashraf Al Amin, the assistant, Dr. Ibrahim, anesthesiology, and the nursing staff, Ahmed and Muhammad Ibrahim, Aziza and Abir and Hind, with Mr. Shafiq, the technician, and the ICOM team. The case will be presented first. The clinical data of the case will be presented by Dr. Ashraf.
We have a 38 years old male patient. He is diagnosed as dilated cardiomyopathy 8 months ago. The patient is in NIHA class 3. He is not diabetic or hypertensive. He is just a smoker. His echo revealed an ejection fraction of 28%. His ECG showed left bundle branch block with a QRS duration of 160 milliseconds, and coronary angiography revealed normal coronaries.
Next.
This is the ECG of the patient showing complete left bundle branch block. Next.
Sinus risk.
And this is the patient's coronary angiography revealing normal coronaries.
It's my pleasure to introduce Professor Peter to comment what is our plan in this patient as regards the strategy and what we have done up till now.
Okay. Thank you, Dr. Ali. So up to now we've gained access. We have 3 access here. And through a safe sheath, we have a long CS sheath, and through that a DAG with a lumen catheter now in the coronary sinus.
We have already implanted the RV lead.
So yes, the RV lead. Can you see the cine up there
Screen.
on the screen?
Okay, Professor Mustafa,
So
can you see the image on the screen? Yes. And the RV lead is already implanted, and a third wire for the left atria of the right atrial lead. It's not implanted yet. We will start the LV lead implantation. First, we will go with the long sheath into the CS by sliding it over the CS.
You can see there's a hook to the CS ostium
this
there,
angle,
which needs to
sharp
be
angle in the CS.
negotiated.
I will try to go deeper.
So one way to be able to access easier is to pull back
pull
on the DAG.
pull and push technique. Yes,
Exactly.
by pull and push technique, the
That's,
CS guiding is already in place.
And counterclockwise
Okay.
on the sheath. Very good.
Yes. Typically, we do angiogram using Swan-Ganz catheter. Contrasting.
So now Dr. Ali is introducing the Swan-Ganz catheter in through that sheath. And this will be used to obtain.
Yes. Nice. Okay. First, we use typically 10 millimeter of contrast. Sometimes we dilute it in other 10 of saline. The typical projection is the AB projection, direct AB. If we are not sure about the origin of the tributaries of the CS, we use LAO or RAO views. It depends, but typically we first start with the direct plane AB views. What do you think, Professor?
I agree. 10 to 15 cc's of contrast is usually sufficient. I think the AP view gives you the most information, and maybe that's all you need. As Dr. Ali said, though, if there's some question or concerns about specific branches, then we can look at different projections.
Yes? No, during the cannulation. During the cannulation of CS, usually we use the LAO projection. Screen.
Although I would say I would typically use the RAO projection. I think it's a matter of preference.
Yeah, yeah. Sometimes I use the plane AB again.
Or AP too.
Yeah. If I am using an ambulance left, typically I do it in the AB view. Okay, seems good.
Could maybe
I
center up
think
a little
I
bit
go
better.
back a little bit because we are over a branch here. I don't want to make any trauma. Okay, I think we can do the angiogram directly without inflation of the balloon.
You
Okay.
want to see a bit more of the.
Yeah, because there is a branch here.
Yeah.
Seni, start. Okay, it seems a good branch. We have a good posterolateral branch. Do you agree?
Yep.
Okay.
Nice.
It's a nice branch, no need for inflation. Yes? Yeah. Okay. Yes, Professor Mustafa? Yes, I hear you. Yeah, I hear you. Okay. The most important step in CRT implantation is good vein selection. In order to get the myocardium resynchronized, we should go with the CS lead as far as possible from the RV lead. The typical best site are the posterolateral position in the mid and basal segments. So we must do angiogram of the coronary sinus. Swan-Ganz catheter will block the coronary sinus and allow the contrast to fill all the tributaries of the coronary sinus. It makes better angiogram, but it's not necessary to be that better because it is safe not to inflate a balloon inside the coronary sinus if we can avoid this. So we tried the direct injection at it reveals the two good, very good branches in the posterior and the posterolateral position, and we are going to target these branches. Freeze. Yes, freeze, please, the angiogram. Shafi, freeze, freeze. CS lead.
Going forward. A little more forward. Yeah. Just. You want to see that posterolateral branch? No, one at a time. Okay. One more. Good. Good. That's good.
Okay. Yes, exactly, Dr. Mu'taz. Yes. Introduce us.
I'd make one other point
Okay,
that
would you please?
yes, I'd make one other point that it's not always essential to have to do a coronary sinus angiogram. Most operators do, but in some patients with significant renal dysfunction, it's also possible to place the coronary sinus lead in a good position without using an
Yeah.
angiogram.
Just by negotiating the branches directly with the wire.
Yes.
Which vein would you prefer? ممكن تجيب لنا road
Right.
map?
Which view?
road map. يعني لا
Now, which is this wire that you're using here? This is-
Okay, it's
Nice.
directly into the wire.
Nice.
Okay, the posterior. Do you prefer the other branch, smaller?
No, this is
branch
good.
of
This is
branch?
nice.
LAO. It's not
Looks good.
EV. EV.
Yeah, looks nice.
Yes. It is a 6 French lead. Yeah. 5 or 6? Yes, a BT2 light support wire. So here. Yes, the wire is retracted to do testing of the lead.
Can we bring the image
Okay.
up with the lead in?
Screen.
Do you want to bring the next? Yeah.
Now is 12. We'll check connect.
Not touching the knobs, the electrodes. It can be inside the lead, but not too distant.
Plus, the other advantage to take the wire out is to see the natural curvature of the lead and be sure that it's stable in that branch. One other point I'd make for the audience is this is a bipolar lead. You see two poles at the distal part of the lead and just proximal to that. Do you use much quadrupolar leads in Egypt here?
When it is not cost, as regards the cost, not issue.
Okay.
Okay, but for cost limitation, most of the time we typically use
Okay.
the bipolar lead. I wish to cut this. You hold this inside. Yes.
What do you want to do? Yeah.
Bull beside me. Yes.
Why did you cut?
No, this is out. To be out.
Okay.
Well, not to be too long outside. No, it's out.
That's okay. Good.
Okay.
Yes.
Can we put a saline on the
Yes.
I'm sorry, could you repeat the question? Do I usually use an angiogram?
CT angiography.
Oh, no, not typically. We
How much sensing?
we wouldn't do that. We typically go with the approach we've taken here, which would be to do a
Basic.
angiogram
Basing?
during the procedure to define the
Basing?
anatomy, not previously to the procedure. As I mentioned
Based on
earlier,
basing? At 10?
it's a more common practice now, or increasingly common practice now, to try and avoid contrast usage,
Okay.
and to try to place these leads without the use of any contrast angiography at all. My own practice is to try to do that first, and then
Okay.
if there are difficulties obtaining access to a good vein, then at that point
Just happen.
I would do the CS angiogram.
Okay.
4 blocking, 3 not blocking.
Okay.
Oh, a coronary angiogram. Oh, I see. I see. Yeah, that's a good question. We certainly could have done that. I think it's not always, and again, different practices, but it's not always clear at the time of a coronary angiogram that the patient is going to proceed with a CRT device. Had it been planned out that way, of course, maybe that would have been an advantage. But as you know, in clinical practice, we don't always proceed and predict those types of decisions.
3. 3 is in the bottom.
Yeah. Yes, I am measuring the LV lead. Sensing is okay, but the pacing threshold a little bit high. I will try to retract the lead a little bit. Okay, it is a double curved lead, an S-shaped lead. It's usually very stable.
There was a request to see the lead in LAO.
RAO, please. RAO. I will try to advance in RAO view, but I have to avoid the apical position. I think more advancement will be near to the apex.
Yeah.
Yes, Dr. Samir.
It's
No, it is an apical septum, not true apex. Yeah, screw
Yes.
in. Yeah.
active fixation.
Try again the threshold.
8, 5, 10 volt. No panic.
Okay.
5. Facing extraction. 4.
Yeah, the BCI wire is too much long for the CS lead. So typically I use 30 or 40 millimeter outside the tip of the lead when it comes out from the other end. So I can handle this short distance of the BCI wire with no concern about to be anywhere and can be out of sterilization. You do this?
Hmm?
This cutting?
No, actually,
Yeah,
is it possible?
the ECG can be
Threshold is 2.4.
0.4,
2.4.
2.4.
At 0.8 milliseconds.
Okay, I wish to go to the other vein, if you don't mind.
Yeah,
Okay.
yeah.
This vein, I think, is not optimal. It can be a potential target, but I will try the other vein, the more lateral vein. Screen.
The question that comes up frequently is what kind of thresholds do you accept? And would you accept a good threshold in a not so good position, or a less good threshold in a good position? What's your...
The better position is always wins.
Yeah,
So better position is our target.
okay.
The threshold can be managed by programming, but the position cannot be managed anymore. Do you agree?
I do. I certainly do. I think I would certainly take a good position over a better threshold. It's a trade-off, of
Oh,
course.
yeah.
I mean, you know, if the threshold is very high, then that's clearly suboptimal. But I think for to ensure that the patient has the best chance of response, knowing that certain lead positions are more optimal than others, it's important to go for a better position rather than a better threshold.
but I think both positions are optimal. Do you
Yeah.
agree?
Yeah. Now this is a good
Yeah.
position
good-
too.
yeah.
Looks nice.
So if the other vein was not optimal, I would never
Yeah.
try to change the position.
Yeah.
But this vein is small. I hope
Yeah.
the lead can pass easily inside it.
Looking good.
Okay, very good. It goes.
And then
I will
you.
try to correct the position of the wire.
So it's important to get the wire as far ahead as
Yeah.
possible for stability. And then as you advance the lead, then you can pull the wire back to
Yes.
allow the lead to track over the wire. You see that jump forward there? Very nice.
Yeah, good. That's a better position,
Yeah.
I think.
I think it's good.
Okay. Start measuring.
Can we maybe see an LAO position too, just for the audience to see
I'm already scanning.
while we're checking thresholds?
Check out regular estimation.
ECG, please.
Yeah.
ECG during testing.
Yes. Now I'm 10.
Do you see it now? Can we put the other screen of the ECG on live?
Okay, now I'm 10. Wait or
At 10?
continue.
Okay, 10, no diaphragmatic basing. Okay, continue.
Okay. 5. Pacing is captured.
Okay,
4. Pacing is captured.
okay, 3, yes. 2,
2. Pacing is
1,
working.
go for 1.
1.5.
Okay,
1.4. 1.3. 1.2. 1.9. 0.8. 0.7. 0.6. 0.5. 0.4. 0.3. 0.4 is threshold. Threshold is 0.4. Okay. go for
Point
next.
4.
0.4. Very well.
Okay. Cheese. Cheese. The third cheese. Cheese.
Estetar?
لا cheese. الاتريوم.
Another cheese? Yes.
اتريوم. cheese.
Okay. Yes, I have another.
Yeah. Yeah. Totally agree with you, Mu'taz.
And it's actually not uncommon, especially in patients with very dilated hearts, as is the case here, to see phrenic nerve capture in this
بص
position.
لآخر حاجة بتوجع.
And as the moderator said, here is a situation where having good thresholds is important, because even if we were to see phrenic capture at 5 millivolts, if we have good thresholds, we can certainly program around the phrenic capture if the lead is in a good position. So
the threshold was 0.4
I have 5 milliseconds. Okay.
at 0.5 millisecond. Yes.
which is about as good as it gets.
I think we go for the atrial lead now, right? Yes, yes. The last step is getting the delivery system out. This is the last step. Yes. Because if we are leaving the CS lead with no support by the sheath while manipulating the atrial lead, it can dislodge the CS lead. Okay. No, it's okay. I change the straight stylet into the J-shaped stylet in order to get the right atrial lead into the appendage.
There you go. That's nice.
Okay.
You see the very typical motion of the
Yeah.
atrial lead there,
This is typical move.
suggesting it's in the appendage. It almost looks like the wipers of a car windscreen, back and forth.
Yes. Yes, Professor Alia. Yeah. Yes. Uh, typically we do surgical lead if we have no endocardial epicardial venous leads, venous access. We do surgical lead. The other option is do endocardial LV pacing. Yeah, we should consider this and discuss with the patient. But the epicardial lead has some disadvantage on long term, and the endocardial lead needs anticoagulation. The best is to have a venous lead. This is the best. Okay, it's testing the atrial lead. What? Yeah, it's a cable. No, the same cable. It's okay. Yes, Professor Samir. 3 punctures. Yes, 3 separate punctures. An important tips is not to make the wires touch each other because it do some interference with the sensing and basing. So this wire should be clear, away from other wires.
Wave is 1.5.
Okay.
I will this at 120.
Yes.
Now
Start
I'm
basing.
Yeah.
The B wave is 1.5.
And now I'm 5 volt. 5 volt.
Okay.
For 4 milliseconds.
Yes.
4 volt is now scattering. 3 is working.
Okay.
2 volt is working. 1.5 is working. 1.4, 1.3 is working. 1.2, 1.9,
Okay.
0.8, 0.7, 0.6. 0.6 is losing capture. 0.7 is
Okay, it's 0.7, the threshold in the atrial lead. It's very good. I will change the J stylet into one more time the straight stylet. For fixation. Right?
To reposition, yes.
No, I will not reposition.
No, I mean
that
to
for fixation. I will not fix on the J because it makes the extra loop in
I see. Yeah,
the. When I retract the J, I find extra loop because it was stored in the J.
I see. Yes.
Yeah.
Okay. No, I would have just pulled it back and then.
Okay, we are ready for lead fixation now, and then the final step will be getting the introducing system out. Okay, fixation. Yes. It is no a slatable sheath. All of them are pull away. Yeah, normal pull away. Yeah. The CS lead is introduced. What? Excuse me. Atrial and ventricular leads are introduced through a normal pull away sheath without valve. Yes, and just after introducing the lead, usually I peel the sheath away and put the plug in to prevent any bleeding from the access site. Yeah, but this maneuver will prevent any bleeding because the sheath is larger than the lead. This is the site of bleeding. If you peel the sheath away while manipulating the lead, no bleeding will occur, and any bleeding can be controlled by the plug in the sheath. You pull the plug into the hole of the sheath, no bleeding will come out. Okay. No, 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 no more pain. Screen RV lead. Screen RV lead, please. Okay. Ah, yes, yes, yes. Seems good. Okay. I pulled the RV lead a little bit because there was an extra loop. Okay. This is for a live transmission, yes. But it's not the typical condition. Yes. Yes, Professor Gamal. Yes, the patient was on optimal medical, of course. The patient was definitely on the optimal medical treatment, on the maximum tolerated dose of ACE inhibitor and beta blocker and diuresis. Despite this, he is in NIHA class 3. Interest 2 versus CRT. My typical practice is to go for CRT in patient with left bundle. Patient uncontrolled with no left bundle, I try interest. But in left bundle, I think CRT gives better results. And the experience with CRT is much more than the interest 2. Interest 2 single large trial, but we need more confirmation to be so confident on interest 2 like this. But in patient with class 1 indication for CRT, I think CRT should be tried before interest. Do you agree, Professor Peter?
I do.
I wish to hear the comment of Professor Peter about this question again.
Well, I agree. I think that in patients with a class 1 indication, so in this case, in this patient's case, quite a significant left bundle branch block related to his familial or dilated cardiomyopathy, I think CRT is a proven therapy, and so I would agree. I would go with CRT at this point since he's on otherwise optimal medical therapy.
Okay, the final step now, which is slitting. Yeah, or yes, yeah, definitely.
That's
yeah.
a very good point.
Because of financial issue, definitely. This is the only reason. Because this patient is typically CRTD will do better in this patient for sure, but the financial issues may constrain us. Yeah. Screen.
Yeah, it's prolapse in the tricuspid valve.
The right atrium is a little bit needs some retraction. Yeah, it's okay.
Yeah.
I think this position is good. Okay. Screen. I start slitting the lead. The introducing system is now out. Okay, this letter is not too good. Okay, I will continue the slitting after be sure it is out. Okay, screen. Okay.
There's quite a bit of slack in that CS lead
Yes.
too, isn't there?
I will get the system out fully before continue slitting because the slitter slipped. Okay. Yeah, but I typically use the AB view. But we can check the LAO view. هتلاقوا. Okay. The most. Yeah. Okay.
I would say I don't typically look while I'm slitting anyway, so
The
it's,
most important to have a
it's
fixed lead.
irrespective of the view.
The most important thing is to see the lead fixed in place while slitting. EB. Yes.
I just slit actually.
Yeah.
I don't look.
You don't look
I don't
on
look.
fluoro? Oh,
No.
this is a little bit brave.
You know, if it's going to move, it's usually going to move. It's
I-
actually very
I-
rare to dislodge
I
with slitting, actually.
need your help to fix the lead or to slit.
I'll fix the lead if you want.
Okay,
If I can
okay.
manage it.
You can come this way. Yes. I will do.
This way.
Yeah.
Okay, let's just see here.
Yeah.
All right, I have got it.
Okay. Good. Thank you. Okay. Good. It's out. I start lead fixation. Okay.
Good.
Good. Thank you.
So
Screen.
yes, I would typically
Yeah.
before we fix the lead down. So
Okay.
as I was saying, I would slit without looking and then
Yes.
look in AP view. I take the moderator's point about LAO where you get the largest view of the lead itself,
Stop.
but really the tip position is what you're interested in. And then check thresholds again just to be sure there's not a micro dislodgement that could sometimes affect thresholds significantly.
Now 5 volts. So facing is capture. 3.
Okay.
Capture. 2.
So it's looking good.
1.5.
Yes.
1. 0.9. 0.5.
Okay.
0.4. 0.3. Okay. 0.4.
Do you understand? Would you please
Can you speak up a little bit?
speak up a little bit? Yes. Yeah, thank you. Of course, when you are dealing with the CS anatomy, we should be prepared for everything. Subselector is available. If we need it, we would use it. Again, different wires should be available because sometimes the target vein is too tortuous and it will be a little bit hazardous for the vein to deal with a hydrophilic wire. In this case, a cyan black or cyan blue wire will do well. Sometimes we go for a vein in a target position through a collateral vein, not directly. If we fail to get the vein antegradely, we can reach the vein through a collateral vein. So everything is possible, yes. The life is cut. Are we on air? I don't hear anything. Okay. Okay. Now we are already fixing the leads are already fixed. We will start to connect the lead with the battery. Okay. Yes. Okay. Yes. One moment. Accelerate. No. Okay, we are going now to implant the battery. Yes, okay, thank you. This line, typical.
If you're washing the pocket?
Yeah.
Yeah.
For washing the lead.
And the lead too, yeah.
Yeah. Atrial first, yeah. I connected the atrial lead first. I can't hear anything. Do you hear anything?
I hear some discussion, but not very loud and not very well.
Look at the QRS complex now. It's too nice to see it narrowing. No, we cannot exactly measure it. We need a 12 lead ECG. Excuse me? Yeah? Yeah, it was 160, 160 or 165. Yes. I hope so.
Yes. You mean if there's little?
صورة بقى كده من فوق لتحت.
Can you repeat the question? I think you said is narrowing of the cuirass a good? Yes, I think it is.
لورا. LAO RAO. لورا. Yes.
Yeah, I mean the way I would think about it in a simple way would be to try and normalize the ECG as much as possible.
No.
In other words, with delivery of CIT, we take a left bundle branch block pattern, narrow the QRS complex, and result in an ECG that looks as near normal as possible. I think those really are the endpoints for CIT, at least in my view. And I think there's good evidence that they're associated with better outcomes than obviously less narrowing of the QRS complex and a less normal looking ECG. Would you agree?
Yes, definitely. Yeah.
I think the point was also made earlier by one of the moderators, or someone in the audience at least, about the heart rate, and I think it's also important to make the point that CRT implantation is just the beginning of a journey for this patient, and that careful monitoring and in particular ensuring more than 95 to 98% delivery of CRT is essential. As implanters, sometimes we may forget that.
Mm-hmm.
Me personally is subclavian. Dr. Ali used a subclavian vein approach here. I tend to use fluoroscopic guidance for an axillary vein approach, just as a sort of, I think, maybe lesser likelihood of pneumothorax since it's extrathoracic. But I don't find cephalic vein cut down particularly useful. But again, it's an operator preference and training.
Do you think cephalic vein can withstand 3 leads?
You know, that was my other point. I think that the advantage of cephalic vein cut down in devices is to reduce the likelihood of subclavian vein crush.
Yes.
But if you take a very small, as is often the case, cephalic vein and pass 3 leads down it, I'm not sure you necessarily have any advantage over an axillary vein or subclavian vein approach.
So final step is skin closure, and 2 minutes we are done. Okay, any question from the panel? Professor Mustafa? Okay, I would like to thank Okay, thank you very much. It was a pleasure to be with you today. Thank you very much. What is the floor time? قول لنا كام الفلور تايم؟ استخدمنا الحالة دي بس في قد ايه؟
So floor time looks like 16 minutes. 16.8 minutes.
16 minutes. 16 minutes, yes.
Pretty good.
Thank you very much.
Thank you. Nice job. Thank you. Very nice job. Thank you. It's my pleasure to watch you work.